Hello everyone, welcome to this Vulval Pain Society social media live. I'm Sheren Gaulbert, Vulval Pain Society trustee, therapist and pain science educator. As always, please say hi in the comments box or chuck an emoji in there just so that I know you are watching. And any questions that come up as we go through today, please pop in the comments too. And keeping an eye on what's coming in is also Kay Thomas from the Vulval Pain Society in the background. Let me just see. Okay, right. So do say hi in the comments box if you're watching. I can see Kay's in the background. Of course, if you're watching the replay, feel free to comment too. So today we are covering a really important topic of vulval cancer, risk factors, self-examination and management. Hi, lovely to see you all here. Thank you for commenting. It's nice to see that I'm not on my own. Brilliant. So our guest today is our very own David Nunns. Hi, David.
Hello.
Hi, David. For those of you who don't know, is the founder of the Vulval Pain Society and trustee. Dr. Nunns is also the current chair of the BSSVD, the British Society for the Study of Vulval Disease. He's the clinical lead of Vulval Health, a multidisciplinary team at Nottingham University Hospitals NHS Trust. He's a consultant in gynaecology, oncology, and vulval disease. Consultant Gynaecological Oncology Surgeon. Now, David, I know that you have a presentation to start off with today before we go into any questions, and we've got a lot to cover. There will be some photos during this, not of vulvas, because, you know, this is streaming live to Facebook and we can't have vulvas apparently, but they're going to be pictures of other parts of the body to show you what you might be looking for. So let's see if this works. David, go for it. You can start your presentation. Hopefully just people watching, just let us know that you can see it. So David, go for it. Over to you.
Thank you. Thanks, Sheren. And I hope to cover the following topics in this quite short presentations, and then we can have general chat and help answer your questions about vulval cancer, a bit about who's at risk and how self-examination can be of use in detecting possible vulval cancer. So the first bit of the talk is a bit about the signs and the symptoms and how we investigate vulval cancer and treat vulval cancer. We have, on average, around 1,000 women every year in the UK diagnosed with vulval cancer who are managed in cancer centres around the UK. There's around 55 cancer centres. And the first port of call for a patient is going to be usually the GP. And so the earliest signs and symptoms we might pick up may be related to the development of a tumour on the skin. And I'll show you some pictures in a minute of some cancers from other sites of the body, not the vulva. And you might appreciate how that we might pick these up ourselves, or how a GP might pick this up in the practice. But these are skin tumours. These are cancers of the skin of the vulva, and this picture is a picture of the vulva. So this just shows you the area of interest when we're thinking of vulval cancer. The vulva includes mons pubis at the top, the fatty hair-bearing areas, out to the genitocrural folds, we call it, where the thigh joins the outer, where the inner thigh joins the inner aspect of the vulva, the labia majora, and we do include the perineum and the anus in our definition of the vulva. So this is the area that I, as a doctor, would examine if someone came along with a suspected vulval cancer. And there's more information on the vulva on the VPS website. So this is a squamous cell carcinoma of the lip on a patient that I found on the internet, as I can't show vulval images in this presentation. And I tried to think about my practice. What do I see in vulval cancer? And in my day-to-day practices, there's a spectrum of disease seen from very small tumours to much larger tumours. So DermNet .org is a fantastic resource. It has lots of pictures of clinical images. So I have to credit them for putting all the images on the internet. So you can see in this picture, in the center of the picture, a lesion, something to see, something visual, and that is, it looks nodular, it looks raised, it's red, and this to me would be very similar to a very small cancer of the vulva, and the commonest site would be the labia majora, and then the labia minora and the clitoris. So those are the commonest sites that this sort of lump might develop. So these are usually what we call squamous cell cancers. They're off the surface of the skin. Much less common, we get melanomas, which are pigmented lesions of the vulva, which are also cancers. And if you look at this, particularly when this is small, you might understand how it might not actually give you any symptoms. It might give a little bit of itching or soreness, but you might actually feel this if you were putting your Dermivate on, if you had lichen sclerosus or washing. So in the very early stages, you might not necessarily get a very clear symptom, and so this is when we come on to self-examination later on. But you might feel a lump. So sometimes in early tumours, women feel a lump. Or they're conscious of itching, or if this top surface breaks open, then you might feel a sore. Now, this next picture is a squamous cell cancer of the lip again, and I looked at this picture hard, and I would say that this does look like a bigger cancer of the vulval skin that we do see. Squamous cell cancers. It's much bigger than the one that you've seen in the other picture. And if you can just imagine this cancer on the vulva, you're going to have perhaps more symptoms. So the symptoms that you might experience if somebody develops this cancer is there may be bleeding, there may be discharge, there may be itching, or more often pain. So these can be painful tumors. And again, if you put the finger on the area, you can imagine with this sort of lesion that a lump would be felt. It would not feel like normal skin. This would be something that's palpable, much perhaps more obvious in this picture than in the top picture. But nevertheless, both you might feel if you were practicing self-examination on a regular basis. So what we look for is change in the usual, and that's often how women come to us in the oncology clinic when they develop cancer. They notice a difference. They say, I found a lump, can you check it out? Or I've got some itching that's not settling, I've got a persistent sore and I need a checkup. So these are the symptoms. The signs are what we see, and as you can see there, they can be lumps, they can be warty type raised skin lesions, but sometimes you can get ulcers or breaks in the skin that don't heal, and also skin color change, which I'll come on to. So that's those are two examples of perhaps a very small squamous cell cancer of the vulva, which is on the lip, and a larger one. Now, what we would do to confirm the diagnosis following referral would be a small 4mm, what I would call freckle size biopsy of the skin in the clinic following referral. So we need a small piece of tissue to examine under the microscope just from the edge of the tumor to get histology, and that ideally is carried out on the same day as the referral, and a result is back within a week, and this would confirm the presence of cancer. And we would never diagnose vulval cancer, or rarely diagnose vulval cancer, without a biopsy, which is our gold standard. Now, when it comes to treatment, we always focus on trying to treat what's called the primary site, which is the vulva, obviously, and then trying to assess the potential of spread from the vulva to other sites of the body. And there's great progress been made over the years in the care of women with vulval cancer. We had some very difficult treatments historically for women, and now the treatments are becoming much more individualized and less radical than previous. This screenshot reminds me just to show you that some of the technology that's progressed over recent years. The vulval cancer can spread to the lymph nodes in the groin in about a third of women who need an operation. And so we would need to remove, or at least assess, some of the lymph nodes in the groin. And historically, we used to take all the lymph nodes out in all the patients through 2 cuts in the groin, what we call the femoral and the deep femoral lymph nodes. And now we can, with selected patients, instead of taking all the lymph nodes out, which can occasionally lead to lymphedema, we can remove just the first lymph node in that what we call lymphatic chain from the vulva, which is called the sentinel node. It's a technique we use a lot in breast cancer, and we can also use this for vulval cancer. So it involves a CT scan following an injection of radioactivity, and then we can see what we call the hot node at the time of the operation and remove this rather than all the nodes. If the lymph nodes are negative, which they are in most women with small vulval cancers, the success rates of treatment are incredibly high, very high. It's a very curative disease in its early stages. So that's for the area of potential spread. This is following the diagnosis of vulval cancer. And with regards to the treatment of the primary tumour, we do favour surgery as the best option, then radiotherapy and then chemotherapy. So as the tumours are, as you saw from the first pictures, they can be ulcerated, sore, they can bleed, they can be painful, and occasionally can be a bit smelly as well as they're moist. Then surgery is our best option because it gives us very good cure rates if it's completely excised, and the skin heals up very well, and the patients feel much better once the tumor has been removed. So although it does change the appearance of the vulva without doubt. When a woman comes along to us with a vulval cancer, she's very accepting of surgery by and large, because she knows that the tumor has been removed, and if the margins are clear, we've got a good outcome in terms of the cancer. And this is just an example where we would do what's called a wide local excision, similar to wide local excision of the breast for breast cancer. Unfortunately, if the tumor is bigger and if it's involving several sites and the tumor is involving, for example, the clitoris, then that's sometimes a site we see. We will need to remove the vulval skin, including the clitoris and the perineum and the labia. Just a word of warning with this slide. This is from one of our patient information leaflets, and everything is individualized. So this is not a generic standard operation that we offer all women. We do offer women tailored surgical treatment depending on their cancer, but the margin around the tumor is a crucial part of the surgical approach. For the majority of women, surgery is all that's needed. We do consider women for a 4-week course of groin and pelvic radiotherapy. If the groin nodes are positive, that's Monday to Friday treatment at the hospital. usually for 4 weeks. And this uses a machine called a linear accelerator, which generates X-ray radiation beams to the groin and the pelvic lymph nodes. That's really if the lymph nodes are positive and there's a concern about cancerous spread outside the lymph nodes into the deeper pelvic lymph nodes. So surgery for most women in isolation. Those with positive lymph nodes would get a course of pelvic radiotherapy and occasionally chemotherapy. In terms of referral, your GP is your first port of call with your concern, if there is a concern, and you wouldn't automatically go to a gynecological cancer specialist, but you would be referred on, no doubt, a 2-week wait referral. That's when your GP fast tracks you to the hospital for a history and examination by a hospital specialist. Now, it's worth saying that of perhaps 100 women referred on a 2-week wait or fast track referral to the hospital for a suspected gynecological cancer, it's not only 5% of women will have a cancer and 95% of women won't. And with regards vulval lesions, many of the vulval lesions that we see on this fast track pathway are not vulval cancer. In fact, the majority are not cancers. They can be skin lesions that are benign. They can be lichen sclerosus, lichen planus, small areas of VIN, precancerous change. So there's lots of other things that can cause symptoms of and signs of vulval cancer. It's not just cancer. There's a very large number of, as you know, vulval conditions that can produce symptoms that I've just talked about right at the beginning: itching, soreness, and breaks in the skin. Now, your GP will probably refer you on a 2-week wait referral if there's a concern. It's worth saying that the average GP sees perhaps one case of vulval cancer every probably 10 to 15 years, one GP practice, that is. So it's not a common cancer for a GP to easily diagnose. So they probably want to get that referral to the hospital so a biopsy can be considered. And that's, as I say, a gold standard. So GPs don't do vulval biopsies in the practice. So don't be alarmed if you're going on a 2-week referral that there's highly likely to be a cancer. To be honest, the 2-week wait referral system is it gets you seen very quickly. It gets you seen very quickly within 2 weeks at the hospital by the specialist. Once seen by the specialist, usually a general gynecologist, a biopsy is taken, and then you may get referred on, if there's a cancer, to the gynae cancer team. In terms of who is at risk, it's fair to say that women with lichen sclerosus, lichen planus, VIN, which is precancerous change in the vulval skin, and other conditions like Paget's disease, those women do have a higher than average risk of developing cancer. But that group as a whole have a 95% chance of never developing vulval cancer, a 95% chance that they will not develop a vulval cancer. So it's what we call a 5% chance of developing cancer if we just turn that round. Now, you might ask, well, what is my specific risk? What is my exact risk? And we can't easily answer that question, because when we've looked at studies of lifetime risk, we group people together. We do put people together, and we come up with this figure. And that's a sort of common agreement amongst medical staff, that it's roughly about a 5% risk of developing cancer in the skin over what we call a lifetime. And to put that into perspective, it's, for example, there's a 1 in 3 chance that any one of us will get a cancer, but that can be at any point in one's life. So the risk is slightly increased in those patients. So the last part of the talk is about detection of vulval cancer and a bit about self-examination. And Sheren, did you want to mention this leaflet on the BSSVD website? I'll mention it then. This is a new leaflet produced by the team in Manchester. This is the research team at Manchester University and the BSSVD, and it's a colour leaflet for patients, women who are at increased risk, women with lichen sclerosus, lichen planus, VIN, and Paget's disease. But it's perhaps useful for all women. It's quite graphic. It's got the images in the leaflet of the various conditions. So it's I think very useful because it will give you some reality as to what we're trying to look at. And I think that this leaflet would be very useful for medicals and nursing staff as well. So that leaflet is available online, and we can give you the link at the end. So just before I come on to self-examination, in terms of what we're looking for as doctors and nurses at the skin, vulval disease, skin disease, is a very visual specialty, and so we are looking at the skin and trying to not make a diagnosis by just looking at the skin. We're trying to describe the lesions, what we see, and then put those descriptions together to make a diagnosis. So very, very commonly you get aptus ulcers, top right hand picture. These are the little sores that you get in your mouth. They are breaks in the skin. They're acutely painful. You can easily see them as sort of little punched out ulcers in the skin, breaks in the top couple of layers of the skin, self-limiting, they disappear. A biopsy is not needed because they are transient, they're painful, and the skin heals up. So those are ulcers, and erosion is just loss of the top layer of the skin. And fissures, again, a fissure is what it sounds like, a split in the skin, a break in the skin. And you can see this is a long-standing fissure on a finger from dermatitis. So someone's got a split there in the skin. Splits on the vulva are very common, and they're often very transient and heal very quickly. And so does little breaks in the skin, ulcers on the vulva, particularly if there's lichen sclerosus or lichen planus that's flaring up. They will come and they will go quite quickly with treatment. And they're not likely to be persistent if the LS, the LP, is well controlled. Other things to see with regards to colour change, then this is birthmarks are a good example of a very flat lesion that you can't feel. And so a macule or a patch is like a birthmark, is something that we can visualize, but we won't feel because the skin texture is the same. So that's another common skin descriptor. And a lump or a nodule or a mass or a papule, to the layperson, it's a description of something that's to be felt. And this is something palpable. It might not necessarily have a color, but it will be something that is felt. And these can be small or large. A papule is something very small, less than a centimeter. A nodule is something larger. So this is a picture of psoriasis, and this is another way of describing skin lesions. And this is what's called a plaque. And this is not quite like a nodule or a papule, which is quite discrete, but this can be felt over a wider area, a thickening of the skin, something that is raised. And if you've seen psoriasis, people with psoriasis, they do have this quite well-defined area of thickening, raised skin. And this is also something you can see on the vulva. So this is another another appearance or a feeling in the skin that we're interested in. So just bear in mind the context of those descriptors. What we're trying to do with self-examination is we're trying to enable the woman to develop confidence in examining her own vulva. And it's worth saying that there is no optimal way of doing this. We haven't shown that this technique is the best technique to do, because there are so many factors that are going to influence how you or an individual would examine their vulva. And we can't necessarily prove that self-examination leads to a reduced chance of developing an advanced cancer, but it just makes sense that we should teach patients to think about examining their vulva to pick up change, so that you can get that next step, an opinion, a medical opinion. I guess what we're trying to do here is through these next series of slides is really just to give you trying to improve your knowledge of vulval anatomy. And from the very initial pictures of the picture of the vulva, it's helpful to have a basic knowledge of your vulva in terms of the pubic area, the labia majora, minora, perineum, and the anus area, because that knowledge is very helpful, particularly when you begin examining the vulva. And also knowledge of your diagnosis. So if you've got VIN or lichen planus or lichen sclerosus, an understanding of what that condition is and how it's managed. In terms of skills, again, everyone's different. There's no specific way to learn this other than making, I think, self-examination a habit, to make it a routine, a part of your life, because I do think we can learn new skills, and that skill in examination. And I think that the more you do generally some aspects of self-examination, the better you get at it. I can't prove that, but that's my gut feeling. I did the clinic yesterday and asked a few women if they were self-examining, and many of them didn't quite know what to do, but would look if there was a problem. And that's helpful, I guess. But I guess you're trying to look when there's not a problem as well, so that you can be mindful of the fact that there is a problem because of change. And then confidence, and this is a tricky one, isn't it? What do I feel confident in knowing when not to go and see the doctor, or when I need to see the doctor? And I think it's fair to say that confidence is a difficult one. However, many women who've got long-standing lichen sclerosus, lichen planus, VIN, who have this as what we call a chronic disease, more than 6 months, many of them do manage their own condition. They're not under follow-up, and they get very good at knowing when there's a problem. So confidence, again, can develop with your knowledge and with your developing your skills of examination. So, what is this confidence? Do you help? Do you go and see help, or do you just carry on? And I think this is a difficult one. I've tried to scale that over the next few slides, whether you would just keep an eye on things, no medical review, you can monitoring, self-monitoring, and a recheck maybe 3 weeks later, whether you might plan a medical review with the GP and go and get a checkup, or if you need to go and see your GP with a matter of urgency for a 2-week wait. This very arbitrary scoring system. So I've thought of the acronym of SAFE, symptoms, appearance, feeling of the skin, and examination. And I guess what I've tried to do is put the equal importance to the development of symptoms, appearance, and feelings of the skin together. what is apparent is that some women are not able to look at the vulva because of maybe their arthritis of their neck, or perhaps their size is a bit of a barrier, perhaps hip problems, knee problems. These are all very common, but that's fine. That is absolutely fine. Other aspects of self-examination can be thought of, including attention to symptoms and also of feeling the skin. So symptoms on their own actually do not, if you've developed itching on its own, that has got a very poor predictor of vulval cancer, because itching is incredibly common, and it's often due to, it can be due to lichen, dermatitis, VIN, and nothing to do with cancer. So it's perhaps persistent itching where you might want to get an opinion. So persistent itching that doesn't settle, and there's a standard of care. We want you to be examined with a good light by a health professional and a diagnosis made. Now, if you've got lichen sclerosus and you're on your maintenance therapy twice a week, then if you've got itching, new itching, persistent itching, you've had a look, maybe had a feel, then we're going to suggest your daily Dermavate or potent steroid until it begins to settle. If it doesn't settle after about 3 weeks, then you were going to go and see perhaps the doctor for an opinion. If you're using steroids daily anyway, and you've still got the itch, then perhaps you should go and get an opinion from a doctor and a checkup. Again, just to look for that, to support your own confidence in perhaps what the diagnosis is. As much as itch can be a very unusual sign of a symptom of vulval cancer, pain is probably a little bit more important. Persistent sores, cuts, burning. And again, it's the emphasis on the persistent symptoms. If you've got your strategy for your fissuring from lichen sclerosus or your sores, and you've tried your Dermavate for 3 weeks every day and it hasn't settled, perhaps that is worth going to see the doctor, and rather than monitoring. So see the doctor for an opinion rather than monitor if things don't go away after perhaps your 3 weeks of daily Dermavate. If you've got VIN, then I think you wouldn't be using steroids, so you would go and see the doctor for an opinion. And again, if you feel a lump or a nodule or a mass, you're going to go into the doctor fairly urgently to get that examination and possibly a referral. Bleeding and discharge, yeah, without a doubt. If the tumor does bleed, if there is bleeding, you'd still need, if you're postmenopausal, need to get a referral straight away, just for an examination. Now, the appearance of the skin is covered in the next section. Really, what you're looking for is color change, and remember, skin naturally has what is normal for you, but it naturally has generally a pink appearance. There's variation. The vulvar vestibule generally has a pink area. There's ethnic variations in color change, in the color of the skin, but you're looking for a change. Now you're looking with a mirror, a selfie stick, whatever way you can do, and ideally looking at the whole of the vulval skin, as I showed you in the picture, starting at the mons pubis area where the hair-bearing area is, and working down the labia majora, clitoris, perineum, and anus, and separating the folds of the skin to look deep inside those folds for any change. And I think if you've noticed whiteness, skin redness, or pigmentation, or a change, then it's not unreasonable to get an opinion from a doctor as to why that color has changed, why the skin has changed. If you see a lump or a nodule, yeah, that's a reason to go fairly quickly. You might feel it, but you might see something as well. And then breaks in the surface of the skin, cuts, sores, or erosions. These are all terms that we use for open skin that won't heal. So many women with LS and LP can experience breaks in the skin, fissuring splits, but they're usually very transient and they can heal with steroids. VIN patients with VIN who scratch the area, again, it's a form of trauma. It can split the skin, but it does heal up and things do settle down. So after 3 weeks, if they don't settle down or this concern, perhaps go and seek an opinion. And then finally, feeling the area. What you, as you might remember from the pictures, anything palpable that's new, perhaps get checked out. It doesn't have to be like in those first pictures of the lips, an obvious lump, an obvious nodule. It could be just some raised thickening. And I think most GPs won't know what to do if it's raised thickening. They might just refer you on for a biopsy if it's a new problem. Of course, some women with lichen sclerosus and VIN, less lichen planus, I think, do have thickened skin. That the skin can be thick, but that's long-standing and it's not new. So that's fine, and it's managed with a dermavate, or it's managed with VIN, just for monitoring. But it's any new palpable change of thickness in the skin. If you feel a new lump or a nodule, yes, you're going to go to the hospital straight away. And then if you feel a persistent area of soreness, a persistent area of pain, I think that's worth noting. You might not feel a lump or a nodule. You might not feel that the skin is thickened, but when you notice an area of a new area of pain, should I say, on touch, and it just doesn't heal with dermavate or your emollient, then I would consider getting that checked out. And yeah, this is not a prescribed performance, as you might suggest, but it's routine, it's habit forming. You need your good light. You need to have this bit of framework in starting at the top and working down. And this is trying to build this into your life. If you want to do this, or aspects of what I've said, once a month is not unreasonable. Men are told to examine the testicles once a month, but examining the vulva once a month, perhaps for all women, is not unreasonable. It can be more often for some patients with LSLP or those who've had a history of vulval cancer. It's not prescribed, but it's just trying to begin a process of building it into a routine. I think the final thing I wanted to say, Sheren, is just the when I speak to women in the clinics, the response to self-examination is very mixed. It does fill a lot of women with fear about looking and putting a mirror or a selfie phone or something there to look at the changes in the skin. But and that produces an emotional response that can be it can provoke anxiety, stress, worry, fear. People can think the worst when they have a first look. I would say that sometimes it's helpful with a medic, maybe at the vulval clinic review, just to go through what they are seeing and what you as the patient might be seeing and feeling, because that's a sort of a common agreement of what the appearances and the feelings are, and that I find that very helpful for the patient. I say, well, your vulva you've got lichen sclerosus, it's very well controlled, there's no cancer, there's no thinning of the skin, and there's no concern. You've got a little mole or freckle there which you've had for years, that can be ignored, and you've got a little pimple that might be a pimple from shaving, or you might have had a little skin tag there for years, and then you've got an understanding of where you might be starting off from. And I'm going to finish there, Sheren. Is that okay? I'm happy to take some questions.
That was great, David. And I think that's
great.
Yeah, that was great. And I think it's Kay in the background has mentioned some people may find a mirror on a stick useful, or a mirror on a stick with a light useful. And I think you were talking about perhaps using phone, but there are ways to make that easier. Do put your questions in. Have put a link up with the BSSVD leaflet on self-examination, and we do have some advice on our site as well. There's a question here about someone who was diagnosed with a vulval cancer in 2019. It's been 17 months since radical vulvalectomy, and I'm still on nerve pain medication and still find walking and sitting uncomfortable, and also have lymphedema in my groin since lymph nodes were removed. Can you suggest anything I do? Anything I can do? Is that common, first of all, David?
So pain after a vulvectomy is not uncommon. Yeah, it does happen. It's a form. Surgery is a form of injury to the skin, and skin heals. However, nerve ending pain at the site of a scar is not uncommon. It does tend to settle with time. We sometimes treat nerve ending pain following surgery with pregabalin, gabapentin, amitriptyline, the pain modifying drugs that we use for vulvodynia. Those can be considered. The lymphedema, yes, that is tricky, and we would usually get the lymphedema service to assess for a package of care, and that can be massage, support stockings, it can be leg elevation, good skin care. So that I'd like to say is treatable. I'm sorry that it's been 2019 now and it's still going on as a problem. That's a couple of years. Yeah, so tricky, but treatable, hopefully.
Okay. And in terms of risk, are there certain people that are more at risk? So is there a genetic risk? And there's one here, am I more at risk having had SCC as a result of oral lichen planus 5 times in 5 years? What's SCC, first of all, David?
Yes, so SCC, squamous cell carcinoma, that's the commonest type of skin tumor. That's what a pathologist will report on the biopsy. Smaller numbers of vulval cancers are melanomas, where you get pigmentation of the vulva, or change in pigmentation, like melanomas you would see on the other parts of the body. So I would say hard to individualize to your personal case, but there is this 95% chance within lichen planus that you won't get a squamous cell carcinoma in the vulva, and then the 5% chance that you might. So it is well recognized that patients with LP have a slightly increased risk chance of squamous cell cancer. If you've had it in the mouth, a squamous cell cancer in the mouth, we don't have the true answer to this, but I wouldn't suggest that if you're otherwise well, that you're a significantly increased risk of chance of getting a squamous cell carcinoma in the vulva. A body of medical opinion, you might call that, might be slightly divided on that, but it's not logical that you would suddenly have an increased risk of squamous cell carcinoma on the vulva, but it would be increased, and you would have a slightly increased risk, like other patients with LS and LP and VIN.
I hope that's answered your question there. And in terms of genetics,
there's just a message about fusion. I think there's fusion of the vulva, and there's ongoing sort of care of the vulva in lichen sclerosus, lichen planus, and this is I guess these are other complications of the condition with scarring and splitting and itching and soreness. These are sort of ongoing issues with LSLP, but by nature of those symptoms individually, that these are not potential cancer causing complications. So fusion is very common, splitting is very common, but they're not necessarily a sign that cancer is developing if you've had the checkup. They're issues that run in parallel, to the overall chronic nature of the disease.
Yeah. And those of you watching who are concerned about lichen sclerosis, lichen planus, vulval skin conditions, there is a live stream which happened a couple of months ago with Dr. Karen Gibbon, vulval dermatologist, which is available on our Facebook page and our YouTube channel. So I would certainly look that up. There was one here about how would I distinguish between genital warts and vulval cancer?
Good question. Genital warts are benign skin growths of the genital areas. They're common. They're sexually transmitted, and they're due to the human papillomavirus. And cancer of the vulva, as you saw in the picture, looks different. I think you personally couldn't inspect the vulva and look and say this is definitely genital warts, or this is this is definitely vulval cancer. You might get an opinion from, well, if you think if sexual health is likely, for example, if genital warts is likely, there's been some sexual contact with someone who's had genital warts, and then you've developed them, then it's highly likely that they are genital warts because they're caused by a virus and it's skin-to-skin transmission. Then cancer is very unlikely, and often they can disappear without treatment. So if you've developed these little itchy, multiple fleshy skin tags that slowly disappear with time, then that's not vulval cancer. If you've got many warty lesions, fleshy, itchy, all over the vulva, and following recent contact, then sexual health would be the place to go, GU medicine, for treatment, and they'll have a look and they'll be able to tell you with confidence what the diagnosis is. Cancer of the vulva, as you saw in the lip there, they don't tend to have lots of multiple fleshy tags. It tends to be one, maybe possibly two areas of rather than itchiness and irritation, itchiness and soreness and possibly bleeding and pain. So they do look very different.
David, you mentioned itching, and someone here is talking about the fact that they never experienced itching. It has done, but it's still doing a lot of damage. How do I know when it's in remission? Is the question.
Is that the vulval cancer? Or the...
Yeah, it just says mine has never really itched, but has done and is still doing a lot of damage. How do I know when it's in remission? So I imagine, Susan, who you've asked this, you've had vulval cancer. We'll wait until Susan comes back to us on that. Talking about VIN, there's a question about VIN3 lesions.
Yeah.
Yeah. Is there any signs we should watch out for that would suggest the lesions are becoming cancerous?
That's a good question. VIN it's a real spectrum of conditions. So many women who have an area of VIN, and there's a question in the comments about what it is. It stands medically for Vulvar Intraepithelial Neoplasia, which is a precancerous change in the skin. It's a little bit like having CIM, which is precancerous changes on the cervix after an abnormal smear test. It doesn't, it's got a low chance of turning to cancer, 5% chance, and it can cause itching and soreness, diagnosed on a biopsy. So most of the time it can be asymptomatic, or there can be itching as the commonest symptoms, itching or sometimes no symptoms. It's if you have like a VIN and the doctors have said to you, well, this is VIN, there's no real treatment at the moment, we can suggest surgery, or sometimes we use a miquimod, which is that's like an antiviral cream, and you live with VIN, and many women do live with VIN, and it doesn't progress to something of progress to a cancer. What I would suggest is self-examination might be an idea. Often speaking to your doctor about the changes, and then I think the key is back to that safe the safe sort of checklist. So the presence of a lump or a nodule, the presence of pain, soreness that doesn't settle, and skin color change. Yeah. So it's having that level of vigilance in the skin by looking, feeling, and reporting symptoms.
Okay. Something here about any links between vulval cancers and other cancers. So, uterine, breast cancer, ovarian cancers, any estrogen drive in the vulval skin cancers?
Another good question. So the squamous cell cancers of the vulva are not genetically linked to other cancers in the body, such as breast, ovarian, uterine cancer, other gynecological cancers, or women's health cancers. Some vulval cancer is due to HPV, that human papillomavirus. So there can be a link to precancerous cells on the cervix. So that would be a minimum to get a smear test done after a diagnosis of VIN. We wouldn't necessarily do more smear tests. You just ensure that the cervical smear was normal, but it's not linked to other cancers in the body. And it's not linked to family histories. So if mum had it or other family members had it, it won't be passed on.
Now, I don't know what this stands for. Again, you'll have to help me out here. When I go for a checkup of my vulva, my consultant usually looks at my mouth, as I have EOLP also.
So erosive oral lichen planus. Yeah, so that's so lichen planus of the vulva, what we call erosive lichen planus. It's the sort of non-identical twin or sister condition of lichen sclerosus, and some women have one or the other or both. If you've got lichen planus of the vulva, which is the redness, this is a soreness, burning, causes burning when you pass urine. It makes that's a common symptom, as well as sometimes itching. You have a 1 in 3 chance of having it in the mouth, and that's why the dermatologist, usually consultant dermatologist, would look in the mouth as well, just to see if there's any change there. Yeah, because it can be a multi-site skin condition.
All right, so I don't know if you've spotted any more there that I've missed that aren't too personal. So there are a few questions in here that are very, very personal that we're not going to ask. We're just going to make it as general as possible so people can be helped. You can, of course, email
info@vulvalpainsociety.org.uk
questions to be answered. We may take a little time, we're all working as well, so but we'll get back to you if you have particular questions. Let me just have a look if there's any other general ones here.
There's a question about how long should you stop using Dermafate before going for a biopsy. I think that the rule of the general teaching is, if you've got maintenance, if you have lichen sclerosus and you're on a maintenance, or lichen planus on a maintenance dose of Dermavate, say twice a week, and your symptoms don't settle, and you develop itching or maybe an area of soreness, then you would, or a flare up, you might, for want of a better word, that you would use the Dermafate daily, maybe 3, sometimes 4 weeks, provided you were happy with that daily treatment, and then go and see a medic for a review. Now, if there's something there that's sinister, like a possible cancer, then the Dermavate's not going to impact on what that looks like. So you won't see shrinkage of the tumour with the dermavate. That doesn't happen, but you might see improvement of the skin with the lichen with the dermavate. So it's possible to biopsy someone who is using regular dermavate if it's needed. Yeah.
Okay.
And there's a question about the vaccine. Well, the vaccine is the HPV vaccine is available now to schoolgirls, and it's embedded in our sort of vaccination program. It's the anti-HPV. It prevents cancer-causing what we call oncogenic HPV infections. Its main aim is to reduce the risk of cervical cancer, deaths from cervical cancer. That's its main objective. But in the initial studies that were produced, it does also help prevent VIN and probably vulval cancer, although that's hard to completely prove in terms of it saving lives from vulval cancer. But logically, it might go some way to reducing the incidence of HPV-related cancers.
Okay, there's a couple more questions here, David, that have just come in. What kind of fusing can be dangerous?
Well, fusion is a stickiness of the tissue. It is a complication of LS and LP, not so much VIN. The tissue, as it's inflamed, it can fuse together and become sticky and then scarred. So, as such, it's not dangerous to have fusion because it's common in lichen sclerosus, but its big impact is on function. So, sex would be its biggest impact because of splitting with intercourse. So fusion is not by itself dangerous, but it is a sign that maybe the lichen isn't controlled, particularly if there's increasing fusion. So that would suggest that there's either needs to be more steroid applied more frequently or a different steroid ointment. So by itself, it's not a sign of cancer or something life-threatening. It's the individual's function and how it affects the quality of life. Yeah.
And there's one final one, perhaps, as we're running short on time. Why can you have a smear that's negative and skin on the vulva positive?
Positive for HPV. Yeah, that's a good question. The smear test these days test for the HPV virus through the laboratory, and it'll use a sophisticated way of picking up the active virus on a smear test. We don't do smear tests on the vulva for the virus, although you can sometimes get HPV-related VIN. I guess the answer to that might be the fact that the virus may have been cleared from the body. So the cervix has actually cleared the virus from being active. So the virus is negative on the smear test, but the knock-on effects on the vulval skin continue. So the virus is within the cells of the vulva, the precancerous cells, and the skin is changing through the virus. But the active virus is long gone. It's sort of almost done it's triggered off a process in the skin. So the virus tests negative, but the virus impact continues with the skin, this precancerous change. Well, that's one school of thought. It's not proven, but yeah.
Okay. And just really a couple of comments have come in about appointments being cancelled or delayed because of what's been going on in the world over the past year. And any thoughts about that? The delays that are going on to see a vulval dermatologist. Any advice you might give people?
Difficult, very difficult. In the pandemic, we shifted from face-to-face consultations overnight to either clinics being cancelled or the face-to-face vulval consultations turned into telephone consultations. We're not quite sure what the knock-on effect of that is, but we are, I think, speaking to colleagues around the country, we're back to seeing people face-to-face now in clinics, and there's actually an opportunity to split the follow-ups from face-to-face and then telephone, which can work quite well to have a combination of two. But it's ideally, aspirationally, would give people the choice to be seen face-to-face or telephone. Sometimes aspirations don't always complete, but because I guess the big problems are waiting list. There's a comment that someone's been waiting 12 months to see someone. Very difficult, and I think it would be. I think your GP is your first port of call generally. If a good GP, I would hope. I mean, getting to seeing the GP can be difficult as well. As a minimum standard, you need a history taken and an examination, and examined by someone who understands what they're doing in terms of looking closely. If they can't do that, then the referral needs to be made. It's a really difficult one because across a lot of health care topics, we've still got the same issue of waiting lists.
Okay. So I've noticed we've gone over the hour, and a few people have joined late and got a few questions in there. I would suggest that you email
info@vulvalpainsociety.org.uk.
David Nunns, thank you so much. That was super informative. And I think this is such an important topic. And I have in mind that I think perhaps, we need to do another one of these, and with someone else talking about vulval cancer alongside you, because this is quite a topic that's really, really important. Any final thoughts before we go, David?
Really, we are very keen as a health community of dermatologists, gynecologists, GPs, nurses to support women learning self-examination. And I don't think we can easily do that on our own in busy clinics. If people have got innovative ideas, things that have worked for them, techniques, tricks, habits or tips, then we need to know about that, because we can very easily put that together in some form of message that goes out, because it's not all right. I give this presentation on behalf of some of the women I've seen, but it really needs to, it's going to be so individual for women to get into the habit. But all I would say is habit, routine, taking that first step probably is very important, particularly when many women are on this once a year follow-up. I'm seeing it in the chat again. It might be a once a year follow-up. You might be discharged back to the GP for your own follow-up. So we need to know what works and what doesn't work. But just try beginning this process, and I'm hopeful that in a year's time, when we all meet again, or whenever we do another talk on this topic, things will be in a much better place. But please have a look at the leaflet, yes, and see what you think.
You'll see I've put that link up in the comments a couple of times, the BSSVD leaflet, and you'll also find a link to it on our website,
vulvalpainsociety.org.uk.
On a final comment from someone, all about knowing your normal. And I think that's right, isn't it? It's if we regularly check, then we get to know what our normal is. And if there are changes, then it's keeping an eye on that, and then going to see your GP if things don't clear. So for any of you who joined the live stream late, or you wish to watch again, because there is a lot of information there, and I'm glad you shared those slides, because that information is there for people to just go and refer back to. This live stream, along with all the other live streams, remain up on our Vulval Pain Society Facebook page and on the VPS YouTube channel as well. And the YouTube channel also has a selection of informative webinars, recordings from last year. If you're not already doing so, follow us on Facebook, YouTube, Twitter, and that just means you'll be notified of upcoming events. Let me tell you quickly about our next live stream, which is on estrogen, vestibulodynia, and the safety of HRT. And that is with Mr. Peter Greenhouse, consultant in sexual health and a menopause specialist. The date for that, Wednesday, the 23rd of June, 7 p.m. BST. That's all from the VPS for now. Thank you everyone for joining us live, and those of you watching the live stream. Thank you again, Dr. David Nunns.
Thank you. Thanks, Sheren, for doing this.
Thank you, and bye everyone for now. See you next time, Wednesday, the 23rd of June at 7 p.m. Bye-bye.
Bye-bye.